Get started again, but before we start, I should warn you that my accent isn't nearly as charming or elegant as that of Abigail Gewirtz. I find that coming from Milwaukee, Wisconsin hasn't helped me much in the cool accent department, but I'm going to present this case anyway. My name is David Hong. I'm a child psychologist at Washburn Center for Children. And when I came on board about 2 years ago, the timing was very fortunate for me because that was when we were starting our partnership between Washburn and several other agencies, along with Abby's Minnesota Child Response Center. So I was able to get a lot of great training and work toward the goal of implementing and disseminating evidence-based treatments for victims of trauma. My first day of work, I actually got on a plane and flew out to Pittsburgh, where we trained with the developers of trauma-focused cognitive behavioral therapy, which is the intervention that I'm going to talk about today. So I've had the opportunity to meet wonderful clients at 2 sites. One was at Perspectives Family Center, which is a supportive housing site in St. Louis Park. And the other is our South Minneapolis office for Washburn through our outpatient program. One of the wonderful clients, I'd like to share with you his story. I've changed his identifying information and given him the most common name in the world, actually, which is Mohamed. Mohamed is an 11-year-old Somali boy, and he was born in a refugee camp in Ethiopia. Later immigrated to Kenya for 2 years, then immigrated to the United States at age 4. Currently, he lives in 2 different households. One is with his grandmother and an aunt, both from Somalia, and another household is with a different aunt and an uncle. The aunt is Somali and his uncle is Caucasian. And the second household those are the guardians that I have been working with most closely in the therapy. He doesn't have siblings living with him. So the reason he was referred was there were several traumatic incidents that happened to Mohamed. At age 3, Mohamed witnessed the killing of his infant brother and the rapes of his mother and grandmother. This would happen in Kenya, where Kenyan soldiers would target refugee populations, follow them to their homes, and try to steal or get money from them. And if they didn't have anything to give them, then they would perpetrate these horrible crimes. From age 4 to present, another traumatic issue for Mohamed is that he was separated from his mother due to a restriction in immigration. Basically, she missed a critical window, and they were letting through children and elderly. They were giving them priority. So he was separated from her. Another traumatic issue for Mohamed is that from birth to present, really, he's experienced abandonment by his biological father, who actually lives locally here, but doesn't really have contact with them, and has had another family. What the circumstances were was that father was a young teen when Mohamed was born. So he wasn't able to provide or have that father-son bond with him ever in his life. And if that weren't enough, at age 8, he underwent a single incident of sexual abuse by a teenage boy in an apartment. It was a single incident, and it wasn't revealed until much later, so the identity of the perpetrator wasn't ever known. I'm going to summarize the way that he presented just to say that he did meet criteria for post-traumatic stress disorder, and he had both high externalizing symptoms, which were the irritability, aggression, and starting fights with peers, as well as internalizing symptoms, which were the anxiety, the avoidance, the withdrawal, and just feelings of detachment. Mohamed also brought with him to therapy a number of wonderful strengths. He's a very intelligent, very insightful, self-reflective kid. And a lot of what we do in any sort of CBT intervention is thinking about thinking. So we look, it really helps to be able to look at the way or the process in which you think. And he was able to do this quite naturally, which was just wonderful for this particular intervention. He was quite verbal as well. Mohamed was very creative. He likes to draw quite a bit, and in particular likes to draw Japanese anime type characters. And we used his creativity later on in therapy as a nice medium for him to express himself. And finally, he has a very supportive family. His aunt and uncle came with very good parenting skills to start with, which was very nice. Parenting is a component of this therapy, and we were able to use their skills all the way through the course of therapy. So, some basic things about trauma-focused cognitive behavioral therapy. It's a 12 to 16-week intervention typically. It can go longer if need be. Parents are highly encouraged to be involved, or a significant guardian. If it's not possible to have a parent or guardian involved, research has shown that it's still better to treat the child versus having no treatment at all, but it certainly enhances the outcomes to have a good, solid guardian or parent. It's quite directive, and it's components-based. So we go through a number of skills to help children cope with their trauma symptoms, and then get into an exposure piece, which I'll talk about later. Like Abby said, we do a lot of outcome assessments before, after, and during treatment. And also I just want to say that as a model of treatment, it's within the structure of the overall structure, it can be flexible and can be tailored to fit an individual child's needs. So we started out with Mohamed with psychoeducation, and basically this is just teaching him and his guardians what are the normal reactions to trauma. We use a lot of books and pamphlets. Pretty standard procedures for psychoeducation. Parenting is an essential component, and if parents don't have good parenting skills or high-functioning parenting skills, we will help them in the use of things like timeout, positive reinforcement, interventions like that. But all the way through, we do have parents reinforce each component with the child so that they can generalize what they're learning outside the therapy office. So the next component is relaxation. And here what we're trying to do is help give the child a coping skill to handle the physiological symptoms of anxiety. A very standard one is breathing, abdominal breathing. I was trying that right before I got on the mic. It works pretty well. I'd encourage you to take 5 deep breaths, expand your belly, and it's amazing. Let's see. So this can be used all the way through the rest of treatment. Once they learn a skill, we encourage them to apply it as we're going forward with each component. Another component is affective expression and modulation. And this is basically teaching a child what feelings are, giving them names, helping them understand that feelings can be experienced at different degrees of severity. So a thermometer is the analogy that I used with Mohamed. And you can set it from 0 to 10 or 0 to 100 and talk about how intense your anger was that day when you slugged that kid, or how intense your sadness was on a particular day. We also want to teach kids that feelings can be mixed, that you can have several feelings at the same time, and that's okay. A very essential component to TF-CBT is cognitive coping and processing. And basically the idea here is that feelings our thoughts are connected to feelings, and feelings are connected to behaviors. So they form a triangle which is interrelated, and that the most effective way, the easiest way to intervene if you want to change a negative behavior or a negative feeling is through the thought stage. Behind most negative feelings or behaviors, there's a negative thought. And I'm going to give you some examples of this. Let's see. We look for cognitive errors that kids make. For Mohamed, one of his was, if it's not perfect, why do it? So this is an example of black and white thinking. And it came out when he was making a drawing, and he would start over and over and over again, going through several sheets of paper. And what we did was we actually used the metaphor of using pastels, black and white, and color different grades of grayness in between the black and white, and talked about how there's many degrees of two opposites. And he was able to work with this and then go through the triangle to help him apply this to other areas where he used his kind of all or nothing thinking. Another example is it's often easier for children to identify or work with the cognitive errors in other children versus their own cognitive errors. And so we would give some examples of this girl who comes from the manual of TF-CBT. Yes or no, Yasmin, who was an all or nothing thinker, and she thought, if the world isn't safe all the time, or if the world was unsafe one time, then it's unsafe all the time. And then I would turn to Mohamed and say, well, what's going on with yes or no Yasmin? And he could identify then what were the cognitive errors that she was making, and what would be more helpful or more accurate thoughts that she could use in her assessment of the world. Another cognitive error that he would make is he would attribute it's my fault. Basically, with his father, he blamed himself that he was felt rejected by him. And what we did was we went through a line of processing in which we looked at that belief, talked about why are other reasons, alternative reasons that his father may have not been able to be there for him, and talked about the situations like, is it your fault that your father was a young teenager when he was born? Well, no. And then another line of questioning was, is it your fault that there was a war going on and there was a lot of chaos at the time? Well, no. And so eventually getting to the point where you can replace the unhelpful or inaccurate thoughts with more accurate thoughts. After these skills have been worked with and mastered by the child, then they're ready to go on to the trauma narrative. And the basic purpose of the trauma narrative is to desensitize the child to the trauma. Since the trauma happened in general, this memory has been a tremendous burden to them, and has weighed very heavily on their consciousness. It's been controlling and starting a lot of dysregulation, negative thoughts, negative feelings, negative behaviors, and has really just taken control of their life. And so what we want to do is give that control back to the child with these skills and with this exposure. And we use the medium of story for this. So one thing that we want to do that I did constantly with Mohamed is that I wanted to remind him and his guardians of the rationale for exposure, because it doesn't make a lot of sense to anyone to get picked up from school, drive across town in rush hour traffic for several weeks to go talk about the worst things that ever happened to you. And so I would use the analogy of a scary movie often for Mohamed and his guardians. If most kids that I have seen the movie Chucky, and I talked about that scene when Chucky jumps out of the closet, and how did you feel the first time you saw that? Well, I felt really scared. It was freaky. And then go through more questioning. Well, what if you saw that again? You think you'd feel as scared? Well, not so much. What if you saw that 5 times? How scared would you feel? And it would go down and down and down. And that's the rationale It makes sense to kids, although Chucky still freaks me out. So yeah, as we're going through this exposure, there is kind of a sweet spot that we want to maintain for the child in terms of their level of anxiety. If you underexpose a child to anxiety, they're not confronting the issues enough. They're not being challenged by them, and the memories will remain to have a very powerful effect on their thoughts, feelings, and behaviors. But if you overexpose them, you certainly run the risk of re-traumatizing them. And so you want to keep the exposure or their level of anxiety in the middle. And it feels, as a therapist, feels like I've got my hand on a dial and that I'm watching very closely to cues and encouraging the child to communicate what it is they're feeling all the way through. Once we've finished writing down the narrative, what we do is reprocess the narrative and look for any further unhelpful thoughts that have maybe originated during traumatic episodes. And then once they're identified, you can challenge them again, find more helpful or accurate thoughts, and clarify things. One of the final stages of therapy is that this is a key component for the parents to be available, is that the guardians will listen to the narrative, a presentation of the narrative by the child. And before we do this, we want to assess readiness of the parents, because they can often be traumatized themselves secondarily to hear this. And so we'd never want to have a situation where the child was able to handle the narrative, but looks over to the parent, and the parent is obviously anxious. So we might need to do some parallel desensitization with parents along the way. Once they are ready, we also coach them in praise just to reinforce the fact that the children are confronting these difficult memories. And I might have silent cues like a second base or first base coach would do, like when I do this, say, good job, you're very brave. After we've done this, then there's an opportunity for both children and parents to clarify any lingering questions that they have about what happened in the traumatic incidents. So often these questions get buried very, very deep because these are the incidents that no one wants to talk about. And so there is an opportunity for them to clarify things. Finally, we do a stage in which we help the child understand that they can take measures into their own hands for keeping themselves safe. And this is basic safety planning, identifying 3 people that you would talk to if anyone ever tried to hurt you or hurt you. How to call 911, things like that. And finally, we celebrate with a graduation. And all the way, we're reminding them that there's an end to this. There's an objective here. And once you're through it, once you've reached your goals, we can celebrate this. You can move on with your life, and these memories don't have to have as much power as they had before. So that is my presentation, and I think Abby's going to go back on, and then we're going to have some time for Q&A. Thanks for your attention.
Well, thank you, David. What a beautiful way to really illustrate some of the concepts that we've been talking about. And the opportunity we have now is to talk a little bit about, in a way that was sort of our introduction to what we can do to help kids who've been traumatized. And so what I'm going to do now is just spend a little bit of time talking with you about interventions for traumatized kids and in general, and I'm going to give you a little bit more information about trauma-focused cognitive behavioral therapy, the intervention that David used in particular, so that you, if you are interested, you can go and get more information. First of all, what I want to say is I'm going to try and, I'm trying to be broad because I know that we have a broad audience here of people who both do therapeutic work with kids as well as people who work with children in many different ways, whether it's educators or people who are sort of public health workers or people who maybe work in other frontline situations like shelters, for example. And there are different levels at which we can offer services to kids who are traumatized, obviously including both clinical and what I would call non-clinical interventions, i.e. interventions, things that can, strategies that can really help and don't require a mental health professional. So I'm going to cover both psychotherapy interventions, which of course trauma-focused CBT is one psychotherapy intervention, but also a couple of other ways to intervene with kids who've been traumatized. Acute crisis response, I'll talk a little bit about what can be done to identify and offer services to kids in the acute aftermath of a traumatic event. Preventive interventions, so what can we do for kids who you know have experienced something traumatic, but may not meet the criteria for a diagnosable disorder, at which point you would provide treatment. And those are preventive interventions. And I'll just spend a little bit of time on multi-system initiatives. So for those of you who are interested in sort of systems perspectives, those kinds of perspectives on serving kids who've been exposed to trauma. So some of you may be familiar with critical incident stress debriefing, and so I sort of find the best thing to do is to be really straightforward. Critical incident stress debriefing in particular, psychological debriefing in general, is the most well-known and widely disseminated approach for people who have been traumatized. The vast majority of people who CISD targets are adults. In fact, critical incident stress debriefing, or CISD, was originally developed for emergency responders. The idea was, and it actually came out of a military model, if you ask people to tell you what they've been through and give them an opportunity to talk about it, i.e. debrief, you will be able to address and deflect any potential traumatization or PTSD symptoms later. There's actually no evidence. There's actually a lot of controversy around this. This is an example of an intervention that's been widely disseminated with little or inconsistent evidence for its effectiveness. In fact, and I'm not going to spend a lot of time talking about adults because they're not our population today, but while there actually is evidence for the utility of debriefing, period, i.e. the opportunity for first responders to talk about what they did, so operational debriefing, the psychological debriefing is much more controversial. It's particularly problematic when we think about children. The idea that you would take groups of children and ask them to talk about different experiences, because of course each child has their own experience, in a group format, kind of let it all hang out approach, is problematic, because what we find sometimes is that you can have a contagion effect where kids who haven't thought about that, whose experience wasn't that kid's, now is that kid's because that kid's shared theirs. There's also some evidence that sort of intense debriefing interventions can actually interfere with natural recovery from trauma. And the fact is that most people do recover from traumatic events without clinical intervention. That's just fortunately, that's sort of a test to the resilience of the human spirit. So it may be harmful, and so I'm just going to be very clear about, and this is why we need evidence. We need to gather evidence about interventions. Psychological first aid is a different kind of intervention. There is some emerging evidence for its utility. It's used by the American Red Cross. It was developed by a group affiliated with University of California, Los Angeles, Bob Pinus's group. And it is a primarily psychoeducational tool. And the goal of psychological first aid, it's been used mainly with disasters, Hurricane Katrina, for example, to provide a lot of as much information to people as possible about what you can expect to think and feel and about, be like after a traumatic incident. So there are guidelines for parents, and there are guidelines for teachers, and there are guidelines for working with children. Like I said, there is some emerging evidence for its utility. Then there are acute interventions. One example I'm going to talk to you about is the Child Development Policing Program. And these are interventions that partner first responders with mental health clinicians or social service workers to do a few things. One is to identify people who are exposed, kids who are exposed to traumatic events. The second was, we talked about the barriers to identification. And so, if you think about who are the people that see traumatized kids, well, police see a lot of traumatized kids. So if you really want to go right to the source and find, and be able to identify kids, then you're going to partner with the first people who are going to see them after a 911 call, for example. The second goal is triage, really, to be able to be a bridge to services so that if people do want services, they have the opportunity to get them. So often people are kind of left floundering. They have no idea what's out there. And then the third is to provide psychoeducation, again, similar to psychological first aid. What kinds of things do you expect to see? And that's kind of a normalization of responses, or it could be, a pamphlet telling parents, here's what you can expect to see in your children, and here's what to do if your kid's symptoms don't calm down after a month or so, which is, of course, the diagnostic threshold for PTSD. So I'm going to start by talking a little bit about what David talked about, which is trauma-focused cognitive behavioral therapy. David gave you a lovely example of TF-CBT with this little boy who dealt with so much in his short life. Trauma-focused CBT was developed, as David mentioned, by Judy Cohen, Tony Manorino, and Esther Deblinger, who actually are in separate places, two in Pittsburgh and one in New Jersey, but developed similar models together and finally decided to collaborate. And there's really good evidence. Trauma-focused CBT is the child treatment with the most evidence for treating childhood trauma. I'm sorry you can't see it very clearly here, but you should have it in black and white on your slide. I would strongly encourage any of you who are interested in TF-CBT to go to the website, tfcbt.musc.edu. There, you can get 10 hours of free CE training on trauma-focused CBT. It's a really, it's a web-based training for clinicians on trauma-focused CBT. It's free, and at the end you can print out a certificate of attendance, which you can then submit for continuing education credits. And it has video vignettes, the kind of material that David was talking about. You see it in video vignettes that demonstrate different concepts and different components of the model. We are very interested in disseminating trauma-focused CBT. We do that here throughout the state. I mentioned earlier we have a collaboration with Minnesota's Department of Human Services, and we are currently midway through a learning collaborative with 45 clinicians in Minnesota in 8 agencies throughout the state who are learning trauma-focused CBT. And a prerequisite for any training in trauma-focused CBT is this 10 hours of training. And these are intervention models that require more than just a one day. Show up and then you're an expert in the field. And I think the field of interventions is really moving forward away from the models of come for a day and you're done to models like David described that include several days of training followed by ongoing coaching. And in our learning collaborative, each clinician gets a 2-day workshop at the beginning, and then every other week video ITV consultation with our consultant in Wisconsin in a group where cases are presented over a period of almost a year, followed by an advanced training. And so it's a really nice way to be able to also have peers to really, it's a really good way of gathering practice-based evidence for how interventions work in practice. David covered the essential components, so I won't. But these are the sort of stages that David described in TF-CBT. And you really, I think you did such a nice job of talking about those. Let's go on to talk a little bit about preventive interventions for traumatized kids. And by the way, I'm not by any means saying that trauma-focused CBT is the only trauma treatment. If you are interested in trauma treatment in general, the last slide in your packet has resources. I would encourage you to go onto the National Child Traumatic Stress Network's homepage, nctsn.org, and there are lots of treatments listed there, as well as the standards by which they have been evaluated. So, so this is just trauma-focused CBT is one example. So evidence-based prevention. What is evidence-based prevention? These are programs that are not therapeutic, i.e. they don't have to be delivered by mental health professionals, although sometimes they may be, that have clear empirical evidence for their effectiveness in reducing or eliminating violence, for example, or distress. And there are a couple of very well-known databases. There are more than two, but these are the two most well-known in the US that screen and list these interventions. One is at SAMHSA, which is the same government entity that runs the National Child Traumatic Stress Network, and that's called NREP, the National Registry of Effective and Promising Programs. I'm not sure, but and the other one is at Colorado, the Center for the Study and Prevention of Violence, and they have the Blueprints programs where they also screen programs and really do a beautiful job of describing the program, describing what it targets, and what the standards were for judging how effective it was, and providing further information. And the kinds of programs that are included in the Blueprints or NREP databases, for example, in terms of, in the context of our population, are the nurse home visitation program, if any of you are familiar with David Olds' program, which was originally designed to be a nurse home visiting program for high-risk moms in their second trimester of pregnancy. It provided 2 years of home visiting by nurses, and the data are absolutely remarkable for showing that over 20 years following the intervention, the outcomes for kids whose parents received the interventions are superior in all ways. The intervention was originally designed to reduce the incidence of maltreatment, exposure to violence. And not only did the intervention succeed in doing that, but if you think about all the cascade effects, if you think about providing support and the right kind of support and education, psychoeducation to a vulnerable, pregnant, young mom, the result is not just less maltreatment, but as a result, a healthier child who shows better outcomes in school, less truancy, fewer drugs in adolescence, fewer arrests, and things like that. So that's the power of prevention programs, where you recruit people who are not showing the problem, a disorder, but are at risk. So there you are. Nurse home visitation is the final one. I'm not going to spend time talking about all of them. You can get them online at the Blueprints, but these are the kinds of interventions that are included. Let's talk a little bit about parenting, my favorite topic. And I'm going to give you the example of the Oregon model of parent management training, which we call PMTO. And these are evidence-based practices in parenting. And anybody who has done parent-child interaction therapy or the incredible years or any kind of parent training, these models are based on the same theoretical principles developed from the theoretical work of Gerald Patterson. And basically, the rationale for parent training is that you offer practices, you support parents to develop or strengthen practices in providing solid, safe environments for their children to live in. And those safe environments, the parenting practices that are associated with safe environments include good, positive involvement with children, so parents who actually enjoy being with their children, effective discipline, good monitoring of children so the parents know what children are doing and are paying attention to them, good parent-child problem solving, so the ability to have effective communication between parents and children. So I know I'm missing one. Oh, and skill encouragement. So parents as their children's best teachers being able to effectively promote behaviors and skills, pro-social behaviors and skills in children. So my interest, parent training has been around for 40 years, but there's not been much written about parent training for traumatized families. And I'm particularly interested, my original sort of group that I worked with were families affected by domestic violence. And in that case, you know, in the whole parent training literature stemmed from an interest in understanding how families are affected by stress, called the family stress model. And the idea is that when families are under pressure, and it could be anything from socioeconomic stress to the stress of transitions, marital transitions like divorce, when families are stressed, the stress impacts the parent's ability to parent. And that's how the stress impacts the child. Primarily, stress impacts the child through its impact on parents' parenting. So for me, that was more than a powerful rationale to think about what happens in traumatized families, i.e. families where, for example, e.g., families where mothers have been abused, or families who've been through war, or other kinds of traumatic events. Most kids don't make it through mental health services, so why not provide something that parents can do to support their children? And parents are often the only available and critical resources for kids. So originally, this model PMTO was developed for all these kinds of problems, and in fact, it has been shown to be very effective at dealing with these problems. And many of the kids in the studies, any of you know multidimensional treatment foster care, that is a PMTO intervention or early intervention foster care, or a school-based intervention called LIFT or parenting through change. These are all variants on parent management PMTO. And I've sort of covered the effective parenting skills, and there are 5 of them. And what we are attempting to, let me just put that back up. And so what we are currently doing in our work right now is saying, okay, we know that these effective parenting practices work in highest standards of effectiveness. Studies time and time again have shown that if you train parents in these parenting practices, kids do better. How much better? This little graph that I'm showing you, it's one of my favorite little graphs, and it shows the probability of arrests since children's parents did or did not attend a 14-week parenting intervention called Parenting Through Change. And so this was a randomized trial where moms who were just divorced in Oregon were assigned either to a 14-week intervention called Parenting Through Change or not. No diagnosable disorders, just, a regular old, you've been through divorce. And the blue line shows the probability of arrest for the kids whose kids did not receive any intervention, kids whose moms went through the group, and the red line, did not go through the group, and the red line shows the kids whose moms did go through the group. And so what you see is, you see an increase overall because these kids were only 6 at the time that their moms attended the group, so they're not likely to be arrested, hopefully, before they're about 10. And of course, what you see in general across the population is an increase in arrests of children across adolescence, but you see how much more likely the kids whose moms did not go through the intervention did, or conversely, what a protective factor this intervention provided for the moms and ultimately the children who went through this group. So PMTO works, and what we have found is that it seems to act not just on kids acting out behaviors, but also on their distress. It helps kids, if you think about those same parenting practices, they really help provide a stable, secure environment for kids who've been traumatized. One could argue that they're even more critical then for kids who've been traumatized. And so what we've been doing is adapting PMTO for traumatized families. I don't really have time. I think I'm pretty close to being out of time. I've got like 5-7 minutes? Okay. So I'm just going to give you a quick example. We're adapting something called trauma-focused parent coaching, which is where what we do is we work with traumatized families. We now actually have worked with 4 groups of traumatized families in the metro area. The first group we did was moms who were in a battered women's shelter, where these are moms who'd been abused, they had very complex trauma histories, and had been exposed to both domestic violence, but also were homeless. They were in a shelter. And we worked with people in the community to implement this parenting through change intervention. And what's really interesting is that parent training doesn't explicitly focus on emotions. And of course, trauma, we've talked about this all the way through this morning, is all about emotions. It's about being overwhelmed emotionally that completely disrupts your regulation. And my feeling, from my hypothesis, to put it in a researchy way, is that what happens to parents who are traumatized is that they are totally overwhelmed emotionally, which really impairs their ability to manage their emotions when they're interacting with their kids. And when that is most clear is when they get into conflict or when they need their kids to do something. And it's much harder if you have any kind of a trauma trigger when you're interacting with your children. Think about how much harder it is to manage your own emotions. Think about how easy it is to get angered or triggered by your kids anyway, and add the trauma piece, and you have a much more complex, difficult challenge. And so what we focus on in our groups is what we call observing and managing emotions. And that is at the cornerstone, the ability to help moms observe and manage their emotions in a way that David talked about in trauma-focused CBT, where the child is taught to label feelings and to understand what feelings do in your body and to think about the thoughts associated with those feelings. We do that with moms as a way to help them manage and structure their interactions with their children. We have adapted this in the context of our center, which is a collaboration of all the entities here, and we have had very, very good findings. Like I said, our first try at this intervention was in a shelter. We tried it at Tubman Family Alliance, which is the largest DV agency in the state, in their Harriet Tubman shelter in Minneapolis. 2 incredible facilitators, both staff at Tubman, recruited 10 moms, and those 10 moms were residents in the shelters at the start of the intervention, and you guys know how transient a population it is. 14 weeks later, 9 of the 10 moms were still attending, and the average number of sessions that moms attended was 85%, which was really, we were just stunned, because everyone told us you could never provide services to such a high-risk, transient group of moms. And I had the privilege of being able to do a focus group with the moms after we were done, and they just talked about how what an incredible support the group was to them, and how it really taught them to kind of take back their household. Because as many of you who work with battered moms know, what's so undermined is they're so powerless and they're made so helpless by their abuser, and they sort of feel like they're now, the household's being run by their children often. And so they talked about how this has given them concrete tools to be able to provide their children with a more secure, safe environment. I'm just going to spend the last couple of minutes talking about collaborating across systems. This is really important in dealing with traumatized kids, because these kids enter into multiple systems. Some of them are in the child protection system, many of them are seen by cops, some of them are seen by hospital personnel, some by firefighters, and no one system can possibly help them alone. And so multidisciplinary partnerships, my experiences with first responders, and that web is just a link to an article about our child development policing program. But the goal is to increase awareness across multiple systems to be able to help traumatized kids. It shouldn't just be clinicians, educators, and shelter workers who know what to do to help traumatized kids. Police officers should know what to do when they enter a home. They should know about how to help 3-year-olds, the importance of a transitional object, things like that. And that's what multidisciplinary partnerships provide. And one of the things, for example, we spend a lot of time training Minneapolis police officers, and we tell them such simple things like, when you walk into a house with a 4-year-old who's just witnessed something terrible happen to his parent, what is the first thing that child sees? What is at his eye level? Your gun, your utility belt. If you get down on one knee to talk to that child in the eye so that he can see you, that will make a huge difference. And those are such simple things that we can really help if we cross disciplinary boundaries to help traumatized kids. I think I'm out of time, so I'm not going to spend much time talking about the CEVI, the Children Exposed to Violence initiative. But the main goal is to really show you that across the country, initiatives have been developed. And those include things like the Green Book or the Safe Start initiative that I consult with that bring multiple stakeholders together within and across communities to solve issues associated with children's exposure to violence. So I've given you a list of EBPs, not an exhaustive list, of evidence-based practices in trauma intervention, practices that really have been shown to be effective with traumatized kids. Other interventions are on the National Child Traumatic Stress Network website. These are just my favorites. And I've given you a list of web resources. And I'm really pleased to communicate anyone who's interested. You've got my email address on the front slide. And I think Joel's coming up, and I'll thank you for your time and your patience.
Well, I want to thank both Abby and David for a stupendous presentation. One of the goals of the Center for Excellence is to help with the bridge between research and practice, and I think these two are just such excellent examples of people who are making that transition from the research world to the applied world, and it's something that we really need and can benefit from. We're about to start the question and answer section, but I just want to talk for a minute to the Greater Minnesota folks. You have the option of either staying online with us and emailing questions to the email address that we've given out several times, but I'll repeat it in a second, or to go offline and have your own local discussion. So please make that decision at your sites. And we'll continue here. If you want to email questions to us, our email address is cmhdata@umn.edu. For those of you who are in the local audience, we have several folks wandering around with microphones. Can you raise your hands, the microphone people, when you leave? And Carrie, okay. So it's your show. Ask questions, and I think we'll get the answers.
We'll try. Yeah.
Well, we need to make sure that other people can hear.
Oh, so the people. Great Minnesota.
Hi. I'm a case manager from Ramsey County. And when you work in this profession, obviously you're in tune with all these kind of things that go on in our world. And I've been paying attention to lately is just the amount of violence in our society, which is pretty prevalent and growing. And I think humor has been a savings grace because it allows us to kind of get through things and laugh about things. But I think, and my question to you guys is, do you think humor at some point has desensitized our perception of what is violent? And then also, a different question too, what do you think are the top 3 contributors to violence in our society? And there isn't a right or wrong answer. I just want to hear what you have to say.
David's going to get that one.
Well, I guess I can just, so has humor desensitized us to violence? I think that certainly the humor that we see in Warner Brothers cartoons, really the kids start seeing from the moment before they can speak, is one example of how kids witness violence and then find humor in it. But I agree with you. It's a two-edged sword. It both desensitizes us to it, but can also be a coping mechanism.
Well, because I listen to a talk show sometimes on the way to work. It's a KQ morning show, and they address real issues that are going on in the world, but they're always kind of splicing a lot of humor in it. And I think it's maybe for them as announcers to kind of keep the pulse of their show and not kind of get too lost into the realities. Like they were highlighting the 4-year-old that was brutally beat in Minneapolis, and I mean it's shocking as to, you know, I mean without digressing any further, but
right, there's a lot of humor that's just crossing the line that they try to push limits, but it ends up.
Well, they had, like, for instance, Tammy Faye, when she was near her end, she, with courage, was on, you know, national audience and said, you know, to all the people that she's interacted with, said, I love you guys and all this kind of stuff. And they had her on there as like, try the Tammy Faye diet, you know. And I mean, that's sometimes humor that crosses the line of what's...
I do think, you know, having spent a lot of time working with first responders, so I've been working with police officers for about probably more than 10 years, about 12 years now. And apart from the fact, I probably shouldn't say this in a large audience, that my alcohol tolerance has increased. The humor is really used in a very powerful way to protect them from the horrible things, horrific things they've seen. And sometimes that's really shocking to people outside, people who are not cops. We took a group of 20 officers and clinicians up to Brainerd a few years ago. Actually, it was about as cold as this, and we had to tow half the police cars back to Minneapolis because it was so cold. But we spent a couple of days together learning about development and policing and trauma. And I'll never forget our wonderful administrative assistant. We were sitting just after hours joking, and they were, talking about just some really awful, gory scenes they'd said. She just went paler and paler and paler. And so, sometimes what crosses the line to us enables other people to continue doing their work. And so it is, I think as David said, it is a double-edged sword. But yeah, humor's a very powerful protector sometimes. So.
Are there questions?
There's one over there. Oh.
Early on, you talked about agitated motor behavior being one of the things you see with PTSD. And I know that that's sometimes part of the way that they diagnose ADHD. Are those two things, are they often misdiagnosed, or are they kind of interchangeable as far as diagnoses go? And
it's a really, really, really good question. Thank you for asking that question. And probably everyone heard it because of the mic. Yes, ADHD is overdiagnosed, and yes, sometimes it's misdiagnosed, and it should be, and the correct diagnosis should be PTSD. And obviously, as you can see, there are some symptoms that are common to both ADHD and PTSD. And so on the surface, a teacher's frustrated with a kid in class and sends the kid to this, the kid's had some disciplinary stuff, and nobody really knows what's going on at home, and the kid, ADHD is a really easy diagnosis to make. A lot of primary care providers prescribe Ritalin. And in Minnesota, there's a problem with access to tertiary care providers in psychiatry. And I think, in greater Minnesota in psychology also. And so these kids get misdiagnosed. And I think it's really problematic because kids get labeled as behavior problems. And what's really driving it is the agitation secondary to PTSD. And there's also a lot of problems I think we're in our we're just learning about how PTSD looks in kids, especially little kids who can't really report to us what's going on. And, you know, add that to the fact that people are avoidant, they don't really want to talk about trauma, or it might not be safe for kids to talk about what's going on. It's very complicated, so thank you for asking that.
Yeah, it just speaks to the importance, I think, of screening for trauma histories when you're doing any mental health evaluation or in general in the general population, because it's so easily confused.
I have a question from outstate Minnesota. This is from Todd County. What about imaginary friends in school-age kids? Is this an indicator of trauma?
Oh, that's a great question. That's a really good question. Well, imaginary friends are part of normal development anyway, so that's the first thing that's important to say. Imaginary friends are, they're cool. They're really protective for kids. Some kids more than others. You know, I think I'm smiling because I was just reading my daughter a book about an imaginary friend, and it's written by a little girl who feels shy and lonely, and she gets bullied in school, and so she invokes her imaginary friend who protects her. Does that mean that imaginary friends, the presence of imaginary friends, is correlated with trauma? I don't know of any research to really to shed light on that. So I would be really careful about making generalizations. I don't think the person asking the question is suggesting we do that, but you know, like David said, the key to all this is doing a good assessment and figuring out what's going on based on history. So yeah.
I have another question from Greater Minnesota. This one's from Rochester. How does a clinician get involved in the intensive training program beyond the 10-week online training?
I did not pay that person. That's great. You know, I can plug, right? We are midway through this year's Learning Collaborative, but if there is enough interest, we will certainly consider doing another statewide Learning Collaborative next year. And so I urge you, if you're interested, to shoot me an email and I'll make sure it gets to the right person. And we will chat with DHS and see if they'll be interested in collaborating with us. So far, I think, how would you report back on our first Learning Collaborative?
Oh, they're wonderful. We have Jennifer Wilgocki as the lead consultant, and I'm an assistant consultant to 5 different sites. And
it's actually 8.
8,
yeah.
okay. Yeah. So, and they're going well. I think it's a very rich learning experience, both in learning the fundamental components of TF-CBT as well as case consultation.
Yeah, I mean, the caveat is that it does require some energy on some effort and resources on the part of agencies. The way we've structured it is we did have a kind of RFP process, so agencies have to be ready to devote the resources to doing this kind of a practice. And they have to be willing to, for example, allow clinicians to devote a certain amount of time to consultation, to things that aren't billable. And the collaboration, Minnesota DHS has been fabulous in that they've provided a mini grant of $5,000 to each agency to offset the cost of the training and the cost of, you know, training staff, which isn't reimbursable. So it's not, you know, it's a little bit more complicated than, hey, I'll do it and I'll join. That, you know that it's an investment. I think it's an investment that's worth it. But certainly, if you're interested, if your agency is interested, shoot us an email and we'll chat with DHS again about doing a second Learning Collaborative. Yeah.
I have a question in regards to violent media that children are exposed to. Is there any age group that would be more affected by seeing, for instance, R-rated movies or cable TV shows? And my question stemmed from an incident in which a child that was about 3 I had seen at a Lord of the Rings movie where they had like heads on stakes and things like that. And I'm wondering if any of that media would affect children or be considered traumatic to them or not, because it's not real life.
Do you want to start?
Sure.
Talk too much.
I'll throw it over to you. But yeah, I mean, there's a certain developmental level that kids need to achieve in order to understand that something is fantasy versus reality, and a 3-year-old is not there yet. That's the same reason that it's not ethical to market to kids is because they don't understand that commercials aren't real.
So I guess my question is then, if a child is like under 5 and maybe only has the, can only repeat, oh, it's not real, instead of knowing that, would that be something that they could take as is actually happening if they were to see it on TV?
Yeah, well, you know, I don't know if any of you have seen Bandura's, the video footage of Al Bandura's now famous experiments with the Bobo doll. I had the opportunity just to show this to my class last week, where young children were shown models who were seen punching and kicking this Bobo doll, and children not only repeated, so they basically, kids were divided into kids who saw, you know, benign, you know, playroom with objects and a person behaving in a benign way, and the same playroom with the same objects with a person behaving in an aggressive way towards this bouncy doll called a Bobo doll. And children, you know, this was the first time that we really clearly saw the effects of modeling. Kids who saw the aggressive behavior were much more likely to model it, not just doing exactly what the actor did, but also finding new creative ways to hit the Bobo doll, using guns which the person hadn't done, toy guns, or using other dolls to bash the Bobo doll. And so, yes, 3-year-olds, I mean, that, you know, I often spend time talking with parents about what not to let your children see, because there is a modeling effect of violent media. So it's hard, and especially for kids who aren't yet of the age to understand the difference between reality and fantasy.
Hi, my question is, how do you help those children that have been through many crisis situations and then a huge traumatic event happens and say within days they're back to their normal schedule, and eventually throw out small questions about the situation but never seem to show that they're really affected by it?
So it's a complex trauma. Is that
Well, I think are you saying children who've been traumatized many times, or kids who just are living a life and then something happens, boom, and then they go back to their life?
Right, and just, I mean, do you address it with them, or do you let them lead it where it comes back up, or do you, you know?
It's a really good question. So let's take a kid, let's take an example of the bridge disaster, right? 35W bridge disaster. We know there were kids on a school bus on the bridge, so as well as kids who were affected by the death of the people who died on the bridge, and kids who lived near or who saw what happened. And that's a single incident, and it's quite possible that it has ramifications. Obviously, for children who lost parents, the ramifications are huge. But for children who went through a discrete incident like that, as a parent, say, or as someone who's with the child, you don't want to sort of shove the incident down their throat. You want to let them lead and ask questions at the developmentally appropriate stage they're at. So in the same, a good example is thinking about death. So we know that children don't understand that people who die don't come back until they're a little older, until they're well into school age. Kids don't understand that death is irreversible, that once you die, you're gone, you never come back. And so trying to explain that to a child who's 5 or 6 years old won't really get you anywhere. So it's much better to follow their lead. The thing is, you have to sort of balance, so now this is, as a parent, you now have to balance wanting to follow their lead and also not ignoring it or denying that it happened. Because I think we often have the sort of feeling of, oh, it happened, it's over, and he seems to be okay, so I'm not even going to go there. And that's not so great, because the children are very sensitive and they get the idea that this is something we don't talk about. So it's a little bit of a balancing act.
What about a child who maybe has made a lifestyle adaptation of just sort of putting trauma behind them, and they may have experienced repeated trauma and just don't have a reaction anymore?
Yeah. Well, those are the kids that we're really worried about if they've made these like developmental adaptations. So delinquency would be one path, or the girl who, the girl who gets into risky sexual encounters as a kind of chronic adaptation to the things that she's been exposed to.
And so those are the kids where it's harder to figure out what has gone on because there's been a lot more time since the event. And that kind of behavior, delinquent behavior, can be a result of many things, not just trauma. And so this is, again, goes back to the idea of assessment and providing appropriate treatment. By the way, trauma-focused cognitive behavioral therapy is not just for kids who have post-traumatic stress disorder. It's appropriate for children who've been through a traumatic event and have numerous different kinds of symptoms in reaction. So general anxiety or depression or acting out, even substance abuse. Trauma-focused cognitive behavioral therapy has been shown to help with all those different kinds of symptoms as long as they're secondary to a traumatic event. So
in those cases, maybe the exposure isn't if a child is desensitized to violence because there's been so many traumas, maybe the exposure isn't the main force of change in the therapy, but some of the skills may take more importance. Self-regulation skills, behavioral management, those types of things.
By the way, David didn't spend an awful lot of time on the trauma narrative, but in kids who've experienced many traumatic events, you can do a lifeline, which basically, I didn't talk about it, but I'm working with some colleagues in Germany who do this remarkable trauma treatment for survivors of war and torture in refugee camps around the world. And they have very simple therapeutic tools. They have a piece of string and stones and flowers, and they use this piece of string to represent the lifeline, and they use stones to represent traumatic events that occurred and flowers to represent happy events, and they do the exposure as a life narrative. That's called narrative exposure therapy for those of you who are interested.
I have another question from Todd County. This is about anxiety at bedtime. How do you determine whether they were hurt at that time of the day or if it is just a way of showing they are tired?
Assessment, I think, asking the child about if anything had happened. Like Abby said, if you don't ask, they won't say it. They won't mention it. And so that would be where I would start with that situation.
Anxiety at bedtime is very normative.
Yeah.
I mean, do we remember any kids who didn't have some anxiety around bedtime? I mean, it's dark, darkness can be scary, and then you have to, and you're tired, and who knows what will happen when you close your eyes for kids who have nightmares and things like that. So I think it's always hard to disentangle, and this is, remember when I was talking in early childhood about how you don't know, what you see in traumatized kids are fears that don't seem to have anything to do with the traumatic event. Everything's multi-determined. And so that's why it's really important to go back and carefully document to the degree you can what happened. I think it's problematic. One of my thoughts is that maybe this a foster parent, for example, who doesn't know a child's history, and that's really difficult. And I just want to acknowledge that's a really difficult situation when you have a child. You take a child into your home and you want to help them, and you don't exactly know what they've been through. I would say that to the extent you can, and to the extent that it disrupts there's a difference between a kid who's anxious at bedtime but who can be calmed down, and a child who becomes hysterical and screams for 2 hours at bedtime over a course of 3 months. And I think we would all be able to say, that the latter child probably, could get some mental health help. So.
We're getting a signal from our timekeeper that we only have time for one more question. I see a gentleman with a microphone in his hand, so.
Well, I'll hope it's a good one then. My question revolves around the kind of families that I work with where there is lots of chronic chaos, and the influence that chronic chaos has leading up to a trauma event, and then trying to deal with the trauma event when the chronic chaos is likely going to continue on some level after the fact.
Yeah, so you have layers. You have chaos, trauma, chaos, and actually, Kathy Spatz-Widom, who I mentioned earlier, has found an interesting finding in her research that what predicts PTSD is not so much the traumatic event as the chaos that goes alongside it, or precedes it, or follows it. And so that stuff, that chaos, the disruptions. I work a lot with homelessness, that other stuff. Sometimes it's impossible to disentangle. Is a difficult condition, and that's actually what got me interested in parent training as an intervention. You know, to the extent that you're going to be able to help, you want to, if you have a child who's suffering from PTSD, then that's pretty clear, and you want to be able to help the child, but you've got to be able to help the family system in terms of helping parents protect their children. We're doing this. I mentioned our pilot of parenting through change in a shelter. We're now conducting these groups in 5 supportive housing sites around the metro area. We've completed 3, and we're just doing the other 2. And these are examples of families who really have struggled with many, many different disruptions, and vast majority of the time traumatic events on top of the disruptions. And the key is to be able to provide a containing atmosphere that can facilitate parents to support their children. So.
Yeah, I'd say at a minimum, if there's further risk of trauma, at a minimum, the child or the victim of trauma can't be still living with the perpetrator of the trauma for this therapy to work. And then you can work around the containment, which as a case manager, you know.
Right, so basic safety, of course, you have to. Thank you for mentioning that.
I want to thank David and Abby for a wonderful presentation, and thank our audience here and around the state. Look forward to seeing you at our future events, and please remember to hand in your evaluations and pick up your certificates of attendance as you leave. Thank you very much.